Good evening once again to everyone, and welcome. And again, thank you for joining us today for our medical talk on fibroids. My name is Linda. We are excited to have you with us today as we explore the topic on fibroids, the facts and solutions. This talk rather is part of our ongoing effort to promote learning and dialogue in the medical community. Our session today will be led by Dr. Fred Carithia, who is our resident doctor here at Calgary Healthcare. Before we begin, just a few housekeeping notes. I will be sharing our social media platforms in the chat box. But if you have any questions for the speaker, please feel free to drop them in the chat box. We will address them during the Q&A session at the end. We'll also be sharing any reference material and useful links. So without further ado, please allow me to welcome Dr. Fred. How about you, Dr. Fred? We are ready when you are.
Thank you, Linda. Good evening. So it's another exciting time that we are here to give a short talk. Just as Linda said, this is a very topical discussion that we shall be engaging in. I'll be giving just general information, and where necessary, we can dive into a more technical bit, but there's absolutely no intention to convert the audience into experts in management of fibroids for obvious reasons, but this is a sensitization that we are doing. That is Calgary in collaboration with our partners and of course our clientele. So I'll give a few preambles. Linda will be controlling the slides as I move along. I'll try to make it brief and simple in a simplified manner, because it can be very technical, but it can also be very simplified. So you can go to the next slide, Linda. Yeah, that is part of who we are at Calgary. We run both the medical outpatient clinic and we have a day theater where we do those listed services. Next. Again, these are our other things that we do in the facility. It's a comprehensive facility where we aspire to provide all services under one roof for the benefit of the clients. Can proceed. So today my short topic is on fibroids, explaining what they are, some of the myths that we've encountered, both in the corridors of hospitals and out there, including social media, facts that we need to know, and solutions to the problem. The picture on the left side of my screen shows an illustration of female reproductive tract, which shows the uterus. It looks like an inverted pear. It's pear-shaped, tubular structure made of muscles. And then on each side, there's fallopian tubes, and the ovaries are also attached. This is quite simplified. The lower part of the uterus is the cervix, which is another structure of interest. And then it extends downwards into the vaginal opening, then to the outside. Let's keep moving. So this is a brief outline of what I'm going to speak about this evening. You are at liberty to interject if either the sound is not audible, or in case there's something that I need to attend to. But in the meantime, we will be opening the chat section so that somebody can be typing questions or concerns even as we proceed. So we shall be defining what fibroids are. We shall speak briefly about the myths, and there are many. You know, each society has certain myths of concerning fibroids. So we may not talk about all of them, but generally we want to tackle what are the common ones. Then discussion on the risk factors for fibroids, the symptoms to anticipate, other conditions that may mimic fibroids or which resemble. In medical lingo, we use the word differential diagnosis, which means what else can present as fibroids and it is not. We also talk about the possible tests that we have in terms of diagnostics, the treatment modality that is available locally and globally, and the information I'm sharing cuts across. It is not necessarily about what we do in the country. And last is what considerations do we have when choosing the modality of treating this problem. We can move to the next slide. So as a way of introduction, we know that fibroids are benign growths or swellings which are found in the wall of the uterus. The muscular wall of the uterus is called myometrium. And that's why sometimes they're also called myomas, which means they are growths, benign growths in the wall of the uterus. Grossly, when you look at fibroids, they appear as hard fibrous tissue whose consistency is different from the rest of the uterus. And consequently, as they increase in size, they cause mechanical problems, mechanical compression or pressure to the rest of the uterus and other structures around the pelvic structures. So fibroids generally grow over a long period of time. They grow slowly, increasing in size. And for most people, they do not cause any symptoms. So it is not uncommon to find somebody carrying a very huge fibroid, which is not giving them symptoms other than maybe distortion of body shape, or sometimes feeling heaviness in the pelvis, or other symptoms as we shall be describing. They can vary in size from very minute tumors or swellings to very huge masses, even to the size of a pregnancy, a full-term pregnancy. They are common in the childbearing years, primarily because they depend on the hormones, that is estrogen, progesterone, for them to proliferate or to grow. Can proceed. So the exact cause of fibroid is not actually known. So we talk in terms of what are the risk factors for fibroids. And risk factors are the things which we tend to associate mostly with the onset of fibroid. In other words, you cannot pinpoint and say this is the exact cause of fibroid. We notice that fibroids are more common in the blacks. Studies have been done. Of course, it is mostly linked with the cytogenetics, but the race is an important factor. I mentioned about age. They are commonly within that age bracket. That is the peak. But it is not uncommon to find persons with symptomatic fibroids or fibroids with symptoms, even at a younger age as early 20s. They tend to be associated with nulliparity. Nulliparity are ladies who have never had children, or those who have had children if there is prolonged inter-pregnancy interval, which means there is a very long spacing. Then they're also associated with obesity. We tend to see them more in ladies with obesity. Genetics are thought to play a role too, because you find sometimes you find a family lineage where a number of people have very huge fibroids. So genetics is a factor too. Proceed. So as I said, majority of the fibroids are asymptomatic, which means they do not have symptoms, and they are found more incidentally or by chance. Somebody maybe has another condition, they have a urinary tract infection, or they are being treated for food poisoning. Then when you do a test, you discover they're having fibroids. Others are actually confused to be pregnancy, but when you check, you realize that it is not pregnancy. Of course, having said that, there are broadly two types of symptoms that we find in fibroids, and those are symptoms which are directly related to the fibroids, and there are other indirect symptoms which arise secondary to as a secondary bit. The symptoms that tend to occur, you realize they could be as many, but I've picked these five. One is heavy bleeding. Number two, having very very painful periods or cramps. Sometimes having pressure symptoms in the lower abdomen, compressing the rectum and the urinary tract. Then what you call pelvic fullness, because as I've explained, these are swelling. They are solid swellings on the wall of the uterus, which cause the uterus to be very big. And then we also have a category of fertility-related problems, which could range from complete inability to conceive, or ladies who will have recurrent miscarriages as a result of this space occupation of the fibroids on the wall of the uterus, causing gross or severe distortion. We can proceed. So the question is, why do ladies bleed when they have fibroids? One, that severe denting of the uterus increases the surface area in the inner layer, which is favorable to increase heavy flow. We also know that uterus being a muscular organ, it's supposed to contract and control bleeding by squeezing blood vessels so that they don't keep on bleeding. So what we see is that if the fibroids are gross and big, they interfere with that that part of control via contraction of uterine muscles. Fibroids at the same time, because they are abnormal growths, they can release what you call inflammatory mediators, which account for pain and intense cramping, increased muscle contractions, and then in some cases, part of the pain is because of relative reduction of blood flow into the fibroid, causing low levels of oxygen, or a condition we call ischemia, and that can actually cause pain. Pressure symptoms is self-explanatory, and as I've said, because the uterus tends to be grossly enlarged and bulky, it can apply pressure on the surrounding structures. If it compresses the bladder, then we have frequent urination. Actually, there are people even present with inability to hold urine, frequent urination, and a lot of problems, urinary symptoms in general. There are others who will present with constipation because of pressure applied to the rectum. Others, you're maybe investigating renal function, then you find the kidneys are enlarged because of that gross compression by the fibroids, and that is called hydronephrosis. For those who are sexually active, of course, you can also have intense pain because of the same. There are patients who will present with the constant lower back pain because they can also compress some of the nerves down there called the sacral plexus. Or some people will present with the numbness of the lower back or numbness of the lower of the feet as a result of that pressure effect. Now, I touched a bit on effects on fertility, and it's very critical to know that uterus is one of the most important structure in as far as fertility is concerned, because that is where the baby eventually grows. And even before then, it has to be conducive to allow fertilization, to allow implantation to take place, much as it has to be conducive to allow the baby to grow. So we note that as a result of fibroids, that gross distortion of the outline of the uterus by fibroids encroaching into the cavity may cause blockage of the uterus, the cavity, and that interferes even with the movement of sperms to cause fertilization. When fibroids grow very close to the fallopian tube, they can also compress them and cause a blockage, and that is called tubal factor of infertility. Of course, there are fibroids which will grow and eventually protrude into the cavity of the uterus. They are called polyps. They interfere with the implantation. In the event that fertilization takes place, they may interfere with implantation. They can also produce secretions into the womb, which interfere with the well-being of the embryo. And therefore, it is not uncommon to find ladies with fibroids who have had recurrent pregnancy losses. You can take note of that. Next. Other symptoms associated with pregnancy, in case somebody conceives, fibroids have been shown to be associated with high occurrence of preterm labor because of increased irritability of the womb. They also may cause intrauterine fetal death. These are babies who die in the womb. Sometimes abnormalities of implantation causing recurrent pregnancy losses. For those who go up to term and deliver because of impaired muscle contraction, they are prone to postpartum hemorrhage or excessive bleeding. In babies who are conceived and are carried to term, also we tend to see what we call small for gestational age or intrauterine growth restriction or retardation. And this is partly because of the mother is anemic as an effect of these fibroids, but also fibroids can cause poor placental function. Of course, they are associated with severe pains during pregnancy, they undergo changes which we call red degeneration, which means reduction of blood supply. Fibroids are also associated with high incidences of operative deliveries, cesarean sections, vacuum deliveries. Basically, they are associated with very difficulty deliveries and the attendant complications that may arise, both maternal complications and fetal complications. I mentioned earlier that there could be other conditions which generally would present as though they are fibroids and they are not. I think top on the list, I should have put pregnancy, because sometimes you find you have to check. That's why we always have to check. Yeah. You can have pregnancy alone or a pregnancy and a fibroid. And I think it will be outside the scope of this short talk to go into further details. But there are people who also carry very big ovarian cysts, which could be simple cysts or complex cysts. Pain, because of the pain, it might be arising from other conditions like endometriosis, inflammation of the appendix, what we call appendicitis. There's a condition called adenomyosis in older ladies. And typically, these ladies will come with heavy periods, very, very heavy periods and pain. Pain from these can also be confused with the pain arising from renal stones or bladder stones. Other tumors, such as ovarian cancer, can cause enlargement and, of course, bleeding and pain. Then, of course, there are other soft tissue local tumors. Let's proceed. Now, when we are making diagnosis, yeah, and this is one of the things that we really emphasize, because now this is more on the part of the caregiver. We employ three modalities to arrive at a diagnosis. One is taking history or asking the relevant questions that will help in ruling out or narrowing down the possibilities. So you'll be asked many questions about frequency of periods, the duration, how many parts, whether there is pain, yeah, all those things. In essence, there's no question which is irrelevant. The person asking may not exactly tell you where they're asking, but it's like an interrogation to try and narrow down the possibilities. Then during examination, we look out for, particularly for the size of the uterus, to see whether it is enlarged or bulky or not. As a rule, we always rule out pregnancy. So it's one of the things we keep explaining why we are ruling out pregnancy, even if somebody says they are not at risk of conception. We know, we've encountered a number. Then on the part of investigation, we heavily rely on ultrasound. And again, sometimes depending on what you want to investigate, or if you have other suspicions, you may employ an MRI or even other forms of X-rays. So I'll be speaking a little more about an ultrasound, and I said this is the mainstay in diagnosis of ultrasound, which means it is the most basic and the most useful tool that we use. Because one, it is non-invasive, so you apply a probe on the skin and then it's able to pick images of the uterus and fibroids if they are there. You can use the modality to measure the size, the number, the location, etc. of the fibroids. Of course, you can use this ultrasound also to rule out other abnormalities, which I mentioned in the previous slides. You realize that ultrasounds are readily and easily available. They are relatively not very expensive compared to other tests. In certain cases, especially when we are suspecting pregnancy, we may want more details by use of an MRI. Of course, those who have interacted with that, you know, MRI is quite an expensive test. So in the tail end, I'm discussing the modalities that we have so that I give time for a few questions and answer or reactions to the presentation. Generally, we have about 4 treatment modalities, actually 5. I'm saying 5 because, as the first bullet shows, doing nothing is treated as a form of treatment. In other words, if the fibroids are tiny, they are not causing problems, no symptoms, no risk, we leave them alone. Huh? And that is to say that there are quite a number of ladies who have fibroids. If we are to operate everyone with this, I think the wards will be full. So we only prioritize and use certain criteria to decide who needs treatment, who does not need. Surgery can be performed on large fibroids, especially if they are symptomatic. And there are 2 types of surgery which we may have come across. In the fertility preserving operation, where you remove the fibroid and retain the uterus, that is called myomectomy, which is named after the word myoma. Myoma is a fibroid. But sometimes you may also want to remove the entire uterus plus the fibroid in one sitting. And this applies to people where fertility is not a consideration, or postmenopausal women, or in other certain specified cases where you remove everything. It is good to note that hysterectomy, which means removal of the uterus, can be done through the abdominal wall or through the vaginal opening, or sometimes it can be done laparoscopically, which means you use minimal access to detach the uterus, then you remove. The best approach largely depends on many considerations, which the doctor performing is able to discuss. And of course, one of them is the expertise of whoever is doing it. So you might find somebody is only able to perform through one route, or they're able to perform, but the support systems within the facility do not allow them to try more sophisticated way. Occasionally, we also consider the patient's preference, because you must be explained what is being done and what are the benefits, what are the merits and the demerits, then you make the decision. Then we have the medical modality. There are certain medications that can be used to cause temporary suppression of symptoms, such as bleeding and pain that comes with bleeding. And this is primarily for in cases where you want to buy time, or where you want to stabilize the patient for purposes of the final treatment. And the final treatment is what we call definitive treatment. Now, this medical management are not recommended for long-term use, because especially if you're blocking estrogen, you're inducing artificial menopause, and it comes with all the other associated symptoms of menopause. And you can imagine doing that for younger people in their 20s. It doesn't make sense. There's a treatment called uterine artery embolization. To embolize means to block the uterine artery, and this is a blood vessel that connects the uterus to the rest of circulation. So when you block, in other words, you are attempting to starve the uterus from getting the relevant nutrients, and consequently, it may cause the fibroids at worst not to grow, at best to shrink. There's a new modality in the market. I think there is 1 or 2 centers currently in Kenya doing this, and this is called high frequency ultrasound. High frequency ultrasound treatment is where you use a focused beam of ultrasound repeatedly over the fibroid to make it liquefy and then try to reduce it in size. This is useful for people who may not be eligible for surgery itself, because it's also an option. Now, this is a very interesting question. You might find 2 ladies, they have the same size of the fibroid, same age, same everything. But one has symptoms, the other one doesn't have. So we put up possible explanations as to why these people will have symptoms, others will not. One, it depends on the location of the fibroid. So fibroids which are growing very close to the inner layer of the uterus, otherwise called endometrium, tend to have more symptoms of bleeding and pain. So those kind of fibroids, they are called submucosal fibroids. Of course, the size matters. We said when they are very small, they may not cause any symptoms. As a matter of fact, you can even carry pregnancy to term when they are very small. So size is an issue. The number is an issue. You might have small ones, but many, what is called numerous fibroids. Cumulatively, they make the uterus very distorted. Then other factors which may compound to cause symptoms include infections and the effects of pregnancy, as I discussed earlier. I think that's it. As I said, this was just a highlight of the fibroids. It's a common problem. There's one thing that I need to mention before we entertain a question and answer, and those are the myths that I spoke about. One, people think that fibroids are cancerous. As a matter of fact, they are not. They are benign. The conversion into cancerous has been observed in 0.01% of women. Okay? 0.01 is quite a very small percent. That would mean 1 in 1,000. 1 in 1,000 women. And even for those, there are people who have other underlying or other risk factors to conversion into cancerous formation. So we often find people who have fibroids are there and they are worried about possibility of them being cancerous. They are not. The other myth is that fibroids are common in the age bracket that I mentioned. Of course, I explained that we've had very young people, even in the late teens, with fibroids. And also we've had people even in their 60s with large fibroids. But predominantly the main problem then is the pressure symptom, because by then they are no longer having periods. The other myth that people presume is that the only treatment for fibroid is surgery. And I've actually explained that it is not all the fibroids that we remove. I'll be addressing the questions on the chat. I saw someone asking what is the critical size that we remove. Again, decisions to do surgery depends on the size. And secondly, the level of symptoms, what you call the symptomatology. You might have a very small fibroid, but making you bleed like a tap. So that might warrant removal. Just the way on the converse, you might have a bigger one, which is not causing symptoms. And depending on the clinical judgment, somebody might decide that let's just leave it because it is not interfering with your life. The second thing, the other myth that we observe is that in as far as I think somebody has asked about it, that every time you remove the fibroids, they come back. Of course, but when you remove those huge ones and leave those tiny ones, over time they grow. They tend to grow because these are ladies already predisposed to formation of fibroids. So we try as much as possible to clear all the fibroids from the wall of the uterus. It is true, new ones can form, but remember, you're also focusing on why are you doing the surgery? Primarily, what symptom are you treating? Are you treating excessive period? Are you treating pain? Are you treating infertility or frequent pregnancy losses? What we call bad obstetric history? Are you trying to address the obvious distortion in the body shape for people who have very huge fibroids? Or are you addressing anemia, effect of recurrent anemia as a result of heavy bleeding? Sometimes, because of the diversity of the clientele that we tend to see, the recommendation is that there is no one approach which is applicable universally to every person. So that kind of discussion need to be pursued by the caregiver wherever you are being seen, so that you are given every possibility that can be done, every intervention that can be done, the risks and benefits, and sometimes also try to choose what is favorable to each kind of an individual. Yeah, because you might have a fibroid and maybe you have a heart condition, you have a fibroid, you have diabetes, you have a fibroid, you're obese, you have a fibroid and maybe a cancerous condition on treatment, you have a fibroid and other conditions. So there's no one simplified approach which is applicable to each and every person. So we try to encourage people, when they have a problem, try and get personalized intervention and personalized advice, because that will be more useful. So I will take back the meeting to Linda so that she can open up the question and we see what we are able to respond. Linda, over to you.
Thank you so much, Dr. Fred. I would want to open the floor to anyone who has a question. Please feel free to ask. Dr. Fred is here to offer a response. Dr. Fred, there is someone here who says they missed the causes, risks, and factors. Could you please repeat on that?
Yes, I'll request you to move back to the slide that was having that. So just for the sake of time, we said that they are common in the black race. Yeah, and has been confirmed through series of studies. They are more common in the black population. We gave age as a factor, citing 30 to 55 as the peak. Of course, saying that we've had even younger ages or sometimes older persons presenting with this. Nulliparity, meaning not having children or prolonged interpregnancy intervals. There is association with obesity, and it's also been observed that genetics play a role. That's why you find sometimes these very gross fibroids running in certain family lineages. I think that's what I said about the risk factors. But I also emphasized that there is no one identifiable cause. That's why we talk about risk factors.
All right, thank you. So I don't know if you got to respond to Whitney here, who says rather, when I got pregnant, my first scan at 5 weeks noted the presence of fibroids. Subsequent scans never showed anything. But when I went for an emergency CS, the fibroid were present and had multiplied in number. What might have made the scan not spot them as the pregnancy advanced?
So there are two things that I need to speak about. One is that an ultrasound is largely user dependent. And that means two people can do the same scan on the same day, the same patient. One picks certain details, the other one doesn't, depending on what your focus is. Probably the subsequent scans were focusing more on the baby, and therefore it can explain why they were not being reported. The second possible explanation, sometimes fibroids can be compressed by the pregnancy to make the appearance on ultrasound more or less appear like the rest of the uterine wall, and therefore it is possible to miss in those circumstances. But I would go more for the first explanation, whereby the subsequent scans missed the fibroid. Because once they are there, they don't disappear. They can only maybe get compressed and then express themselves at the point you give birth.
All right, thank you. So Maria also asks, do fibroids cause chronic pelvic and sciatica pain, even when they do not cause heavy or painful periods? Do they
Yes,
also cause stomach problems and also some movement in the stomach where there is no distension?
yes, they do, because as I mentioned, the fibroids will have the pressure effect on the surrounding structures, and I give an explanation where they compress some of the nerves in the pelvis and cause either persistent lower back pain or numbness in the lower limbs, or sometimes pain, what she's talking about as sciatica. I don't know whether I've answered both questions. Yeah, she talked about movement. Of course, the uterus is not fixed in the womb. So if it's big and it's not fixed, sometimes even when you turn, just the same thing that would happen in somebody who is pregnant, you might find there is that we say the word we use in medical terms is ballotable. You find there is that movement, particularly in the kinds of fibroids which are attached by a small stalk, and we call those ones pedunculated fibroids. So it is possible to experience those movements. Okay, next question.
All right. Lydia asks, do fibroids cause infertility?
Precisely, and I explained that in details. I hope she was able to follow through. But the mode of causation of infertility is primarily mechanical compression of the fallopian tubes causing blockage, and secondly, a gross distortion of the endometrial cavity where the baby grows, or sometimes when they grow and encroach, making the place very toxic and unconducive for both fertilization and implantation. I also mentioned that they are known to cause recurrent pregnancy losses, what we call miscarriages, because of those extremes that I've just explained.
All right. Well noted, Dr. So after Jane asks, after the surgery, how long does it take for one to
Generally, we give timelines of about a year, but this is better discussed by the person who is operating, because all surgeries are not the same. Some of them are quite extensive, and the surgeon may decide that you need a bit more time to recover. We also cognizant, especially if they are being done with fertility in mind, we may play around so that we don't let you wait for so long, especially for those women who are approaching menopause. Sometimes we also look at what are the other complications, like people who undergo this treatment and have a complication that may warrant you to get more time off before you conceive. So there are many factors that we look at before we actually tell you, here you can conceive after 9 months or after a year, sometimes after 2 years. Any other question, Linda?
No. I think that's rather those are all the questions that we had. But again, if there is anyone who has any more questions, please feel free.
No. There are questions we wrote from when the presentation started. Please just scroll up the chat space. There are questions from top.
All right. I think Dr. addressed this one for how big is a fibroid considered big for a surgery. I think that one, Dr. you touched on it. And the explanation behind disappearance of fibroids without any medical intervention. Am I right to believe you cover this, Doctor?
Yes, I have. I have explained. I have explained in details. There's a question about what makes fibroid reoccur after surgery and especially intramural. So they don't reoccur. New ones form, especially the ones which are tiny. And you know, when you remove the big ones which are causing problems, the rest are left now to flourish. They have more blood supply, so they grow faster in comparison. So it is not them regrowing, it's new ones growing. And that's why most of the time when we do the procedure, we even want to look for those tiny ones and remove, because they can grow over time. I'm actually looking at the questions. Fibroids and fertility, that one I've handled. Duration after surgery before one conceives, I've also explained. Yeah. The temptation is actually to give you a specific timeline, but as I've said, there is absolutely no surgery which looks like the other. That one we agree, isn't it? And consequently, it is always good to discuss with the person who has, the surgeon who has done the procedure, because they will tell you what was the extensiveness of the procedure. Were there any complications? Are there any concerns about the personal safety? Or what exactly should be, what are the other factors to be considered? Yeah. For instance, somebody who is being done surgery because they have bled and the hemoglobin is very low, you might actually be told to give it time to build and heal fast before you conceive. Others who get operated and maybe they have an infection on the wound and it's taking time to heal. So it becomes very difficult to generalize and say this is the exact duration. I think, yeah, there's a question about effectiveness of embolization. And I said to embolize means actually to inject a chemical in the artery that supplies the uterus. It's called the uterine artery, to sort of block it. And by doing that, you're cutting blood supply to the uterus and to the fibroid with an attempt to make them shrink. You're trying to starve the fibroid. So it is effective if it is done. Sometimes over duration of time, new blood vessels will grow, okay? That process is called revascularization of the uterus, because there are many other small blood vessels which will increase in size over time. Secondly, if the fibroid is if it's huge and causing a lot of mechanical problem, particularly if the consideration is pregnancy as a result, then it may not be the most prudent thing to do, because the fibroid will remain, that mechanical obstruction will remain. The symptoms may subside a bit, but again, should you conceive in those circumstances, then the outcome is not going to be fruitful. So again, these are things which needs to be discussed with the provider so that each person has a modality which is well thought out and appropriate for the individual needs. Thank you, Julius, for that question. There's a question about hormonal imbalance. In case of someone with hormonal imbalance issues, is someone likely at the risk of getting fibroid? No, there's no linkage between hormonal imbalance and the fibroid. The typical presentation of persons with hormonal imbalance is irregularities of periods, lack of ovulation, and delays in conception, and sometimes changes in weight, as is found in women with polycystic ovarian syndrome. Somebody is asking about estrogen and progesterone imbalance. The question is not clear, but these are two very dynamic hormones that we find in the female body. And you find they keep on changing from one day to another. So in essence, as one increases, the other one decreases. And that is how the body is able to get a very coordinated menstrual cycle. That is how the body is able to even determine when to ovulate, when to conceive, and should conception take place, what hormone to increase to support the pregnancy, which one to decrease. So it's a very intricate mechanism which overall is controlled by the brain, a part of the brain called hypothalamus, and the pituitary gland. So we call it an axis because There's input from the brain, the higher centers of the brain, the pituitary, and then the ovary. So it has to be very coordinated. And when that coordination is lost, then that is what we call hormonal imbalance. I hope that is the question Terry Omondi was asking.
Karen, can you hope that you have been answered?
There's one more,
But still,
Linda.
you are,
Sorry?
yes?
I'm saying there's
Okay.
one more
Yes,
question.
there's one more. My mom had,
There's a
yes,
question
then for Cheryl.
about hormonal related convulsions. And last year she got fibroids, which led her to get medically induced abortion. Could it have caused it? Not really clear what it is, but there are many conditions which can cause convulsions, including persons who have endometriosis in the brain, persons who have another underlying brain issue, because largely fibroids do not cause convulsions. And that is why it is essential to undergo a series of tests, including an MRI of the brain and another test called EEG to look at the electrical activity of the brain and determine what exactly is causing the convulsions. Of course, if the fibroids are very huge and disturbing, it may not be tenable to carry a pregnancy, or in cases where the life of the mother is threatened, sometimes the pregnancy may be terminated so as to save the life of the mother. And I believe probably that's what may have been done. But of course, an explanation needed to have been provided so that as the decision is being taken, it is informed and somebody knows what exactly is being done. Does avoiding inflammatory foods reduce occurrence of fibroids? This is not clear what kind of foods you have in mind, but remember we talked about obesity, increased body mass index in relation to fibroids. So probably if you look at it from that angle, then there's a slight role of diet and exercise as a modifiable factor in the management of the fibroids. I think we've come to the end of the questions, and I believe we are not locking anyone out. If we are, let me know.
Thank you, Dr. Fred, for your answers to these questions. We would also like to encourage all the participants present here that in case there are more questions, you are all free to visit us at our KMS Center Hospital at Upper Hill and have a one-on-one with Dr. Fred, and I believe all your questions will have been answered. So in the interest of time, I would want to appreciate everyone, ladies and gentlemen, on behalf of Dr. Fred and the whole Calgary Health. I would want to extend our sincere gratitude to you for your participation and also to Dr. Fred for your insightful and thought-provoking presentation. So thank you all for the engagement, the commitment to continuous learning in this medical field. And we hope that today's discussion has sparked new ideas and offered valuable perspectives that you can carry on in your daily life, and also ensuring that all your queries on different topics are answered. So we are still on with having these regular talks and different topics. You can feel free to share with us what other topics you want us to cover in our consequent engagements like this one. And we hope to stay connected for future sessions. Please follow us on our social media platforms. Join us on our WhatsApp channel, and we'll be able to stay connected. from myself, until then, please stay safe and continue making a difference. Thank you for your time and have a great day. Dr. Fred, you are free to say something as we close.
Thank you, Linda, for moderating the session and the audience. I think I must commend you. Sometimes online sessions can be very chaotic. So thank you for remaining muted. And this participation, we don't take it for granted. Just for emphasis, these are free information sessions. Ordinarily, if you visit and you go to a place, they might charge you to share even this kind of information. But these are series that we are preparing to make sure that we sensitize people free of charge. As Lita said, you're free to visit us at KME Center on the 7th floor for one-on-one. For those who are following from out of Nairobi, maybe one encouragement, if you've been having something that you're not sure, just take an ultrasound. It is painless. It is affordable, because one of the reasons why you find some people having to have their uteruses removed is because they stay with these fibroids until they are very gross and huge, and it becomes necessary to remove the entire set as the only way, because if they are very big, then it also even becomes risky to try and save the womb. Others will suffer these recurrent miscarriages unknowingly, or sometimes they know, but there's that fear people have about surgery. But surgery, if it is done in the experienced hands, in an environment where there is safety and controls by trained personnel, it is one of the safest interventions, because it is people who have been doing the same thing. Yeah. So we shouldn't stigmatize fibroids, because it is part of the things that we see, but it is also one of the things that cause a lot of stress to ladies, including this bleeding, pain, absenteeism from work, social relations issues. Yeah, a lot of expenditure, buying one medicine after the other, and generally what we call a decreased quality of life. So get informed, take action, share the message with your colleagues and friends and family. And we are, of course, even offline, we are available to answer the questions. We hope to share the presentation to those who registered, and you can be free to share it. It is not patented, but we feel it is part of the things that can help one or two persons. From me, I would like to thank everyone who assisted in putting up this presentation, from Shannon, our IT personnel, and the staff here, and wish you a good night. And thank you for your attention. And until next time, it's a good night for me. Bye.
Thank you, Dr. Fred.